talk a little bit fast because I've got a lot of information I want to squeeze in today. But yesterday I was in the hot tub and the phone rang, the jacuzzi over there, and one of my patients' wives called and said, "Hey, your patient, my husband, is very sick. He has bad diarrhea and he's in bed and his blood pressure is low. We checked the blood pressure. What should we do?" So I grabbed my other phone while I was in the hot tub and I called my nurse and I said, "Can you please go to this guy's house and give him 2 liters of saline?" And she said, "Sure, I'll be right there." And then I told my patient, the nurse is on her way. So like that's the ideal world of medicine that we'd like, but that's not exponential. That's linear. I was going to name this talk linear medicine. But one of the things I want to talk about is how to think about medicine. It's a little bit of a meta thought. And you know, as a philosophy minor in college at Berkeley, you know, philosophers only want to know one thing, is what's the right question? And scientists want to know one thing, is what's the right answer? And the problem is if you get the right answer to the wrong question, where are you? And so I want to like frame up this talk about let's see if we can get the right question. So if we talk about omics, I invented my own ohm, which is the trustome. And the trustome is a myriad of attributes that I believe we will then trust people if these things exist. I mean, if we trust something, we move towards it. If we don't trust something, we move away from it. And you know, a lot of it is listening. It's understanding someone's preferences, and it's got to be relevant to them. It's got to be contextual. It's got to be literate. They've got to understand it. It's got to be responsive. It's got to be shareable. It's got to be safe. It's got to be authentic. It's got to be invisible. So, like, how do you create a trustome? So that's kind of one of the things I'm trying to create is that. So what is the right question? What is health? Is it the absence of illness? You know, what do patients really want? And what do doctors really want? And who owns the data? And what's the right paradigm? And so we have a really crazy system that we're trying to like fit all these things into, which is hard. So I'm going to go back to linguistics for just a minute, or go to linguistics. So this is a famous Persian poet, Hafez, which says, "The words you speak become the house you live in." So I think that we need to like step back for a second and say, how do we talk about it? What are the words that we use? So I'm going to show a couple of words that like drive me bananas. So diabetes, you know, type 2. Does anybody know what diabetes means? Not what it does, but what it means. And the answer is no. So here we have this condition that's like 80% of the cost of healthcare, and nobody knows what it means. So we haven't named it really properly. It actually means siphon in Greek, because people peed a lot when they had it. So they named the disease based on what happened after they got it. They didn't name the disease based on what caused it. And so really it's processed food disease and heart failure. I mean, like you just gave someone depression for the rest of their life. Like heart failure, like we need a rebranding of that diagnosis. It's bad. And reimbursement, which is a language we use in medicine all the time, is like I don't reimburse the gas station when I get gas for the gas that they bought. I pay the gas station. And so doctors get paid. But if you heard about a doctor not getting reimbursed, you may shrug your shoulders. But if you heard about a doctor not getting paid, you may go, that's not right, right? And so we conflate a lot of things, we dumb things down, and then providers, I went to Georgetown Medical School, and I promise you I did not get an MP degree. I got an MD degree. Like, I'm not a medical provider. That's not what my certificate says. So call me doctor, call me clinician, don't call me a provider. I hate it. And then the other thing I'll say is that consumers are not patients. And a lot of people want to argue with me on that one, and I will go to the mat all day long. But the fundamental issue here is that consumers have free will, unlimited options. They're excited. They want to spend that money on the thing. They will trade the resource that they've earned for that thing. Nobody wants to come to my store. No one wants to come to the doctor's store to buy something. I mean, not really. And they're anxious, and anxiety is not good. So what is health? Health is a myriad of many things. It is all the social determinants of health that aren't like the attributes of what happens inside your body. It's all the externalities too. So I think this is like, we have to kind of answer that question. This is the model we have now. It's the illness model. We basically cruise along and, uh-oh, I got a problem. Let me get the diagnosis right, and hopefully it's quick. Let me get and there's tons of friction in this system, and it's a horrible UI, UX. Then you want to get the treatment options, because there's not only one treatment option for a problem. There's usually 10, and it all depends on your preferences, going back to trust. How do you listen to people? And then you see the treatment, hope it works. I think we need a health model, which has lots of data in it and lots of algorithms in it, but it's got to be really focused on knowledge of risk factors and advocacy. I mean, these are things that we don't talk about. There's no algorithms for that, but this is where the humans come in, and that's why humanity is important in healthcare. And we need nutrition and personalized fitness and action. So these are the vital signs. These are what we, like it says it in the word, vital signs. So this tells us if we're alive or dead. That's all they tell us. So like, and yes, we measure them, and we've got lots of cool devices that can measure them, but guess what? What about vitality signs? What do I measure when I sit and talk to a patient, right? You know, you live in your body, and your body's a physical thing, and your body interacts with other things. So everything's relational to you in your body and your perceptive organs. So what is your relationship to all of these things in your life? This is what interests me, is, again, just a reframing. So I'm in Silicon Valley. Let's move fast and break things. Let's go exponential. Let's do it. I think that was a quote from Mark Zuckerberg. And this is healthcare. Yeah, we have to move slow and not kill people. It's a little different. But it's the truth. We have to be a little bit more mindful. You can't just throw things out there and hope they work. This is our ecosystem, which I call the freakosystem. This is, I'm not kidding you, this is it. This is all the regulatory things that have to happen. So if you have a cool new app or a new thing, you got to figure this out. And by the way, do you see where the patients are? Oh, here they are, this little thing over here. And you see where the physicians are? Oh, they're that little thing over there. And like the IRS is bigger than patients and doctors in this schema. So it's really hard to plug something into this because we have to fix this. And the other thing, to riff off of John Muir, like who said when you tug on a single thing in nature, you realize it's connected to everything else. It's the same thing in the healthcare system. If you do something here that's good, you don't know what it did that's bad over there because it's like not your money and it's not your problem and it's somewhere far away. So no one's really taking a large systems architectural standpoint. This is John the muffler guy. John the muffler guy, if you go to his shop with a little rattling muffler, you know what you're going to get? A brand new muffler. Because he makes money selling mufflers. And in healthcare, if you go to a doctor and there's an equivocal situation here, you probably are going to get the thing because there's payment attached to it. And that's called the moral hazard in philosophy. And so there's a huge moral hazard in a transactional model. So what model should we have? Well, we should have a moral imperative model where we all win if the best outcome happens, right? But we don't have that. I'm fighting for that up in the Congress and whatnot. But so the paradigm, like what's the right paradigm? I think the right paradigm is that every patient should get the best outcome the fastest, right? And for all the technology people out there, I love you, and I'm building some technology, which I'll go through in a second, is healthcare is a people business that needs technology. It is not a technology business that just needs people. And I think if you get that wrong, you're going to build for the wrong thing, and it's not going to work. So you really have to remember that the people need your technology, and your customer could be the doctor, your customer could be the patient. It could be both. So empathy is analog. It's hard to go faster than analog. You know, we don't think 5 thoughts at once. We think 1 thought at a time, and they go one after the other. And you know, the humans move at the speed of each decision that they make. And what I will say, being a doctor that takes care of all sorts of issues, is that when you admix anxiety, existentialism, and probability, like that causes paralysis of thinking. And if you think an algorithm's just going to speed that up for you, it's not. You're going to have a bunch more questions. You're going to want to talk to other humans that have the same thing. So you can go fast, but you know, that's why I was going to name it linear medicine. So there's 2 reasons to see a doctor. The condition is unbearable, or the anxiety about the condition is unbearable. And that's it. I mean, outside of trauma, but that's the condition's unbearable. And so, you know, this is what drives a lot of healthcare is anxiety, the fear of not knowing, this existentialism. So imagine you just got a diagnosis. It's act 1, scene 1 of your healthcare movie, and you're the main actor. How do you want your movie to end? Right? So who's the director? Who's the producer? Who's the supporting cast? How can clinicians and patients and data write a script together? So inside and outside of the hospital, how does that work? So going back to these questions, what do doctors want? They want to live, what do patients want? Sorry. They want to live their lives with minimal impact of illness. They probably want to optimize their health. They want to have trust in the system. They want convenient communication channels, and they want a sense of support, a sense of control, agency. What do doctors want? I mean, they want to have good outcomes for their patients. They want actionable information. They don't want to be data input jockeys. Like our lives are pretty miserable when you get down into the trenches. What patients don't want is Dr. Google to be the first responder, because he's an oncologist. Because as soon as you ask Dr. Google a question, you're concerned it's not cancer. It's always cancer in there on one of those searches. So that's not the right, and you know, just look at the fake news and stuff. Like it tries to aim stuff to you because it thinks it knows you, but it doesn't know you. So what we need is a continuously learning clinical operating system that's underpinned, that's underpinned by a narrative that honors people. And I'll talk about that in a second. Both sick and well, to keep them connected, and then you need this learning best practice engine. So this movie script has to get smarter based on the attributes of the person. So we should treat engagement like a vital sign. So you live in your body and you engage with data, you engage with people. So engage, if you just think that your body's gonna fix itself and I don't need to see a doctor until something breaks, you're wrong. Your most valuable asset is your body and your health, and you need to invest in it. And investing time is engagement. And it's not just what's the matter with you, it's what matters to you. And it's actually both. So these are all the sensors. Everyone's building sensors to sense things. That's great. I love sensors. It gives good information. But two of the most powerful sensors that have ever been built have been around for billions of years, and they're built into the side of our heads. They're called ears. And unfortunately, we are outsourcing our ears to a bunch of other data streams. And you know, they teach you in medical school that you can get the diagnosis 90% of the time with a good history, with just by listening to the person tell the story. So we're going to move, I'm sure that's going to shrink and data will be collected, but we can't outsource these things. This is where humanity happens. So I put this up here because if I asked everybody to look at this thing and say, you can only have one button. If you had a phone that only had one button, what would it be? So what's interesting is that Apple puts messages, mail, and phone at the bottom. Those are all communication things. And then one's a curiosity thing, the Safari button. And what's interesting is, like, I think that the fundamental unit or the functional unit of humanity is a conversation. That's what we do all day. When you're done with here, you're going to talk to people. You're going to email, you're going to text. All we do is communicate all day long. And with social media, now we can communicate with multiple people at once. But that's all we do is we communicate. We're communicating machines. And in the digital health world, if you look at, this is a little bit old, but if you look at what all these apps do, like they inform, instruct, record, display, guide, and none of them communicate because nobody knows how to communicate in healthcare. So that's the problem I'm trying to solve. How do we communicate? And so patient engagement, if they did a big study at Blue Cross Blue Shield and kind of went through, like, there needs to be a sense of connectedness and continuity with trust, and then that will empower the patient to ask questions and feel confident. And when they have that, they will engage. If they don't have that, they won't engage. People say, why don't those people over there in that county, they're not taking good care of themselves, that you screw them. They don't trust the system. And if they don't trust the system, I don't blame them for not getting good care because, or not getting care because they don't trust it. It's important. So delivery in the future will have these attributes of prevention, surveillance, access and action, and short and long-term planning. I think about healthcare like an asset. Like, you know, when you have an asset, you manage it. You know, you have an annual report every year. You have a strategic plan. You map the plan. If things go off, you modify the plan. So imagine if doctors had a superpower and they could talk to every one of their patients every day. And imagine that patients had a superpower where they could be connected with their doctor every day. So this is the movie narrative. So I started this company. I won't go through the whole thing, but it's basically, I've written movie scripts for hundreds and thousands of different conditions. And it's because, not just me, I've worked with doctors in cardiology and orthopedic surgery and gynecology. And you pick the specialty and you interview doctors. And I tell people, I kind of joke that I come from the future, but healthcare is very predictable. And I know what will happen. So if you had a hip surgery, for example, I know that on 3 days from now, all the questions you're going to ask. And I know that on day 2, those questions are like bubbling up in your reptilian brain, and they haven't turned into anxiety in your mammalian brain. But if I know that you're going to ask that question on day 3, because if you look at the phone logs of an orthopedic practice post-op knee surgery, they all are asking the same questions. You tell them on day 2, hey, you're probably starting to think about this. Here's how you need to think about it. And then we ask them how they're doing. And we get all this subjective information you can put in biometric data too. And then you have this proactive. Now remember, the doctor's not doing anything. They just press play on the movie, and the patient's getting these digital check-ins, and it says, you know, Dr. Shlain wants to check in with you today. That's kind of cool. People don't normally get that from their doctor after a diagnosis or condition. And then it gives you like timely information because we remember the future, and it asks you how you're doing so we can see if you're tracking how your arc of recovery is over time. And if you don't engage, we then pick up the phone and go analog on you and call you. The doctor's office will, because you didn't engage, and we have to treat engagement like a vital sign. Let me go back to that slide. So this is fascinating. This is hundreds and hundreds of thousands, maybe millions of people in this particular N. 86.7% of the people that use this said, because of this, I didn't need to call or make a visit. So all the throughput that's happening, all this friction and clogging, is people just need information. They need to communicate something to you and get something back from you. So this is like astounding, great. And old people use it and young people use it. People like, when I started this thing 5 years ago, oh, old people aren't going to use that. They are the most active group because they're usually older. They usually take their health really seriously. They've lost a few friends. Like they take healthcare a little bit more seriously. And then they use it all the time. I mean, you know, before a procedure, they're like really use it. That's anxiety, like on a graph right there. They're about to have surgery, and then after their surgery, this is 23 weeks later, they're still 60, 70% engaged on this platform. Like, if you tell those numbers to any consumer guy, they'll say, I don't believe you. They love it. The patients, we asked them to score it, and it's good. We did a study at MD Anderson to score literacy. People getting a PET scan to get diagnosed, to get staged for cancer, they show up to the PET scan, and a lot of them freak out, and they have a panic attack. So if you have a panic attack before you go into the PET scan at MD Anderson, you know what they do? They yank you from the line, you got to go get a mental health exam, you got to get a full physical exam, then you come back to get the PET scan, and then you get Valium IV, and then you need a ride home. So literacy costs a lot of money, by the way. So we did this study where we videoed the two guys that were going to do the PET scan, and on the run up to the PET scan, everybody got a check-in every day, which, hey, these are the guys that are going to do it. Here's the machine. It's easy. It doesn't hurt. Had a couple testimonials from patients, and the literacy went up 45%. We just published on Friday, I'm very happy, this has been a long, long effort of mine, a study with Anthem, where we did patients on Health Loop, patients not on Health Loop, and multi-state, practice, age, like all sorts of people, not old people, young people. And what we found is that we could reduce, by using this, $656.52 per patient was saved using this. 45% relative reduction in admissions and 54% relative reductions in complications, blood clots, skin infections, and all sorts of other things. So it works. So this is just some data. I won't go through that. So I think that the digital health movement is going to be all about communication and engagement, and all the algorithms and all the data and all the things that we need are going to inform that conversation. And by the way, I think this is an older slide, but and in closing, a couple brief things that I want to talk about is this is like a brief advertisement for a publication that I am self-funding. It's non-commercial, and it's an ideas blog. It's basically an ideas publication. So if you want to go find out some cool ideas and what some smart people are thinking, I've been curating really smart people to write for me and to spread the good word. I also started a nonprofit called Eat Real. And if you know what LEED certification is, imagine doing that for food establishments. So we've gone to hospitals and schools and businesses and saying, are you poisoning your people? Because if you give them bad food and your cafeteria is serving bad food, you know, you're giving them a rash on the inside, which will lead to a lot of bad things later. It's called internal medicine, not external medicine. So we now have 600 establishments across the country, and so look for this seal. This is going to be, I think, the next important thing to change, because then they will change their buying habits from where they buy it and how they provision it. This is last night. This is what dinner looks like. This is an analog dinner, and then this is an AI dinner. So that's what AI looks like having dinner. Anyway. It's been a long road to get to here. This is what my life's been like, even though it may look like that. So thank you.